Danielak. I'm a psychologist. I've been in private practice outside of Atlanta. Can't tell you for how long. Over the course of the years, I do both counseling and therapy, but I've also been trained in neuropsych assessment, in particular for different types of learning disorders, ADHD, and the cognitive weaknesses that underlie those. And so I've tested approximately 1,600 kids, adults, and children. And I like to kind of keep my fingers involved with research, particularly field research. Obviously, I'm in private practice, and I was one of the, 592 of us who did some field research for the DSM-5, which was interesting. I've also been involved with the APA's quality measure development for the Behavioral Health Initiative. There's an excellent instrument out of Spain called Nesplora, where I helped collect normative data for the United States. And it's a kind of a virtual assessment of attention, and myself and Sam Goldstein and Nesplora kind of compared one of the gold standards, the TOVA, to this instrument. So I'm going to be speaking to you more from a clinician's point of view versus some of the other stuff that you've heard. I wish I could see somebody. I don't know if how many are actually in clinical practice or just kind of want to hear what I had to say. So we'll kind of go with both of them. So here's our agenda. It's going to be simple compared to some of the things you have heard. So we're going to talk about what are statistics, really basic 101, why standardized testing and checklists are different, what you can and can't diagnose from testing, and the most probably interesting part will be the case presentations. So briefly, for those of you in the field, we get all these reports from all these different clinicians, as well as different types of other professionals, and it can be reported in all sorts of numbers, standard deviations, percentile ranks, T-scores, Z-scores, standard scores, scaled scores. It also makes that might be easy for all of us, but it makes it very difficult for your patient to understand what is going on. And just to take you back, if you have forgotten, lucky you, but we're really looking at standard deviations from any kind of standardized testing. So we have a standard deviation above and below, and it continues to go out. I've rarely seen any reported like this. Sometimes they even admit the percentile ranks. There's T-scores, there's Z-scores, there's standard scores, there's scaled scores. When you're talking about data regarding diagnosis of any learning, processing, or attentional disorders. If you can imagine how hard this is for the patient and or the parent to understand. And I always say when I'm speaking to patients that my job is to make sense. Of course, I make sense to myself. It's so that I can translate our data into something meaningful for them. This is a much more simple standard bell curve, which I often use in my practice and with reports, whether they're going to the government, the school, psychiatrist, because this is much easier. I translate all of these different scores that we receive into the standard scores. And if we can get the patient or the parents or the school to understand this, then we're going to be ahead of the game when we present the results. So we have standardized testing, as you all know, that's been validated and researched, and it's got a lot of good credentials, test, retest reliability, and it's been normed on thousands of same age peers or whatever the issue might be. But then we also have checklists, and checklists are standardized, but in the sense of here's many people's opinions, and then how do you fit in these opinions? And so of course it's very contaminated by somebody's biases, awarenesses, or lack of awarenesses. And so just to kind of start first by talking about one of the ones I see in practice all the time that psychiatrists give are these Vanderbilt scales. And the Vanderbilt is an assessment tool where you sit down with pen and paper, and you, oops, I want to go back here. You sit down with pen and paper, and you are, people fill out these instruments, which I'm going to try to share with you here, just in case you haven't seen it, which you probably all have. I have to go back to a different screen. So this is an example. Everybody can see that, all right? Does that work? Yes, can you see this, Vanderbilt? I hope so. Looks like
I
it
don't
works.
have your screen.
What did you say? Can you see this evaluation right here?
No, sorry, I couldn't see that. Could you please share your screen again?
Yeah, I did that, but it doesn't seem to be working. So I will have to go back.
It's okay, it's okay. Take your time.
Oh, I see. You have a little bit different setup here. There we go.
Yes, it's okay right now.
Okay, gotcha. So this is used quite frequently in the field, and this is not one of my favorite tools whatsoever, because my major problem with this is that after you give this to a client, or a psychiatrist does, where's the standard scores? Where do we come up with whether these scores were average, above average, a standard deviation above or below? Well, if you get back here to how you have to score it, you would need to have a fair number of admins to come in and look at all these things for you and figure out if they are in this continuum or not. So normally I have actually never seen one scored. That comes to me from some other outside source. It's usually just they're handing this to me, and they're looking at, oh, there's a lot of 2s or 3s or 1s, and somebody makes a decision. Okay, that looks like ADHD. I'm going to give you meds, but you should get an eval. There's a crossover between the symptoms that one sees with ADHD that you see with inattentive type, that you see with dyslexia. And so without testing, you may be giving medication for the wrong thing. For instance, I've highlighted the items that could be not about ADHD, like does not pay attention to details or makes careless mistakes with, for example, homework. So the primary deficit in dyslexia is reading, or phonics to be more explicit, the inability to remember the sound letter combination. So these children start off being behind their same age peers when they're young, may have a lot of problems with early phonics. They usually, more slowly than their peers, catch on to reading, but they're behind by several years. Their rate is usually slow, their comprehension is bad, their fluency is low. And so reading by what, 4th grade is everywhere. You can't go to school without reading. So look what they look like they're doing. They look like they're not paying attention, and they're making careless mistakes. Is this because they don't read well and they can't break apart new words? They have problems paying attention in class when basically the teacher's speaking a different language, because dyslexia is a language processing disorder, and they're having a hard time processing, reading the board, taking notes, and they don't seem to be listening. They might be listening in math class, by the way, but not so much when it comes to anything involved with language. They may not follow through on instructions. Yeah, what if they don't even read the directions because it's too many words? And so they, guess what? They avoid and they dislike a lot of things. They're easily distracted in this class. It's language arts class, it's English class, social studies, anything that has a lot of language in it, because a lot of reading, because they're struggling with that. So they can look like they're fidgeting. They can even just have to go to the bathroom all the time. They argue about whether they're going to do this topic or not. And then they, of course, don't say they have anything to do with it. They blame others and they lie. Yes, I have that done. Yes, I handed it in. and they are sick a lot and don't go to school a lot. And so there's a lot of symptoms that could, again, we think we're looking at ADHD, but we could be looking at anxiety, depression. Also, these things can be secondary and caused by problems with learning or attention. Now let's see if I can switch this out a little bit quicker this time. So we can go back to this. All right, did that work? Can you see my slide presentation again? No, because I don't hear any of you. So let me come back to, see if I can get into the smaller version. The moderator, can you see the PowerPoint again?
Yes, sure. You can keep going.
Okay, so are we on the assessment page or just back to the beginning that you can see? No? This isn't responding like it was before. I'm going to try it again. It didn't look right. All right, so hopefully we're on the page that says what you can't assess from standardized testing. Is that what you see there?
It's all right. Yeah, I see your slide.
Okay, so you see the slide that says what you can't assess from standardized testing, correct?
Yes, correct.
So typically all of the emotional disorders, it can't be measured in a standardized fashion. I often get a referral question of whether or not I can diagnose bipolar and ADHD. Well, I could definitely diagnose ADHD, but bipolar, no. That's something that a good clinician will figure out with time, correct? And patterns and looking at the understanding the patient and how their moods swing up and down. We could get a sense of that from the checklist, but now we're back to checklists versus any kind of real standardized cognitive testing. I may put on a report, a rule out, but that would be the extent of it, including a major depressive disorder, cyclothymic, disruptive mood dysregulation disorder, which is often part of ADHD, persistent depressive disorder, and all anxiety disorders. So our experience in the practice and clinical practice will be our best bet for assessing this. But what we, why is this not advancing? So you do not see the next one that says what you can assess. There we go. All right. So the obvious, we can assess IQ. Why do we want to do that? The reason we want to do that is it measures different types of processing, some of which are implicated with ADHD, some with dyslexia, some with depression, and it also highly correlates with how well a student is going to do in school or adult in college. It's not predictive, it's a correlation. And so we use that as we look at other cognitive skills. And so obviously we can diagnose and test all the cognitive deficits apparent in ADHD, both combined type and inattentive type. We necessarily need to make sure there isn't any other learning disability, such as dyslexia, dyscalculia, written expression disorder. We can actually measure different types of executive functioning because executive functioning is impaired in a variety of diagnoses, such as autism and ADHD and depression and many mood disorders. There are many components of executive functioning that will not respond to a change in medication, including working memory. So as a clinician, when you have a person coming back in and saying, well, this medicine's not working, I can't remember anything, it'd be very useful to know what their working memory score is, because medicine doesn't impact working memory directly. And so for the less obvious, as I've been talking about, these things can look the same on checklists. In attentive type ADHD and dyslexia, they have the same sort of symptoms in the classroom, at home, at work. Working memory, we can measure visual and verbal, we can measure rote and complex. There is not an increase in working memory because of medication. Working memory precedes all other types of memory. It's a frontal lobe function. I like to say, it's like you want your working memory to be Velcro, but if it's like a colander with a lot of holes in it, these people cannot remember things that they learn, and then it therefore will not go back into their intermediate memory or their long-term memory. And so all these executive functioning deficits would be really useful to understand that this person may or may not be able to inhibit, plan, follow through on multi-step directions, notice small details, switch attention between two tasks. And so guess what they can't do? Listen to their wife and remember what she's saying, or listen to a lecture in the classroom and take good notes. There's many things that involve 2 and 3 tasks as we switch attention. Problems with impulsivity, processing speed can negatively impact everything. Inconsistency of performance. Now, you know these things, but what I'm saying is that we can measure these things. So the common psychiatric features that they present with are like many other things. They can come into your office or my office seeming like they are depressed and they want to be there for an assessment or treatment of that. They can have anxiety about school. They can have anxiety about work and about anything they might have to do at home. And they can sometimes just be outright kind of refuse to do it, or better yet, be very good at procrastinating. So they start to then perform poorly, whether it is at home, in the classroom, in a job, and they start to just kind of isolate in these settings. They complain, they can't remember what they read. Well, what's causing that? Is it a reading learning disability? Is it a read comprehension issue? Is it processing? They make a lot of careless errors. I don't like those two words put together. So far, I haven't met anybody who could really care less about the output, but that's what we call them. So they make small errors in math, they make small errors in big projects that are due at work. Sometimes they can exhibit oppositional behavior because everything has been so difficult for them, and they start to get in a pattern of how they behave. They can present with feelings of hopelessness, which right away we think of depression. They can have relationship problems. They can have a poor work history. And, they can, as I've mentioned before, these two can present with many similar psychiatric features. So it can be difficult to kind of decide, does this person need an eval? I think it's important to understand and also be able to test and measure executive functioning weaknesses in ADHD, because these, after you hit 12 years old, these are the problems with ADHD, not attention and not focus. They have problems with much bigger executive functioning skills that we know to be prefrontal lobe functions. And we have the most densely packed prefrontal lobe of any species. So these are the things we can do that I tell parents our dogs can't do. Or if you have ADHD, you also struggle mightily. So they can struggle to have any persistence with any kind of goal-directed activity. We call that sometimes sustained attention. Metacognition is that ability to, how do I get that to go back? Geez, I just clicked this thing and it's going forward. All right, I guess I have to do something else. Sorry about this. This is a really kind of different PowerPoint for what I'm used to. I cannot tell what you guys are seeing. The moderator, are we on the slide that says executive functioning weaknesses in ADHD?
Yes, we have weaknesses in ADHD. I can see that.
Okay, I didn't know why I can't see it. Sorry. So anyway, planning and metacognition is this overall awareness of what's my day going to be like? What do I have to do? How do I get ready? How do I keep track of it? Where am I at now? Not losing time as they go about their day. Planning is a huge executive functioning weakness that really impacts anybody above the 6th grade and way into adulthood, which includes prioritizing and understanding what comes first, second, and third. And if they're on the combined type, they have a lot of problems with inhibition, the responses, the inability to kind of stop and pause and think. And we know that up to 60 to 70% of people with ADHD can have problems with emotional regulation. This goes back again to this executive functioning as part of our prefrontal lobe. This is our CEO. So as it struggles to regulate all these other functions, it definitely also struggles to regulate mood. So these persons can come into the office looking like they have a mood disorder, and they can, and they do, but is that all that they have? So they struggle with sustained attention. This is measurable. Task initiation, that's also measurable. Time management, that's a big struggle for them. They can't keep track of how much time something's going to take. And they're not very flexible sometimes in their problem solving because transitions are hard for them, and they can present as anxiety alone because of their inflexibility and their problem solving weaknesses. And working memory, although non-executive function, is a core deficit of persons with any attentional disorders. And it precedes all of the types of memory. And so it's going to manifest in problems with forgetfulness and poor performance at work, at school. And I'm sure it's a common complaint by a patient out in the field. And this is not something that can be changed with medication, working memory. I'm probably not, I'm just going to touch on this. When they present to you with problems with what look like attention and maybe actually get a diagnosis as such, and then the parents or the person comes back and says, geez, I still can't remember anything in math. I don't know why that's such a struggle for me. And so ADHD is most impactful academically in math because there isn't a subject that requires more memory constantly. What a child is working on today was dependent on what they remember from yesterday and the day before that and the year before that. And even as they're working within a formula, they have to remember, what do they do next? What's the order? What happens after that? There's many moving parts in working with math. And so that often comes up. I often see it overlooked, even though a child can have a learning disability in math as well as problems with attention. So, working memory causes problems. They can be slower processors where you're throwing many balls in the air doing math and you have to catch them and do them in a timely manner. It's really hard for them to separate out irrelevant associations, which are always part of math, which is important here and which is not. They can't switch attention between tasks. Well, even a mixed addition subtraction worksheet is switching attention. They have a problem with noticing small details. We can also measure that and kind of predict that. And so they don't have, as we know, this, what we call this reward deficiency neural pathway, where once they get something done, they feel good about it. And so they really are missing that. So they don't have this like dopamine hit after they finish math. And they're also bad at math. So they don't want to do it at all. So the funnest part is, in my mind, is all these different case examples where people presented with things about, I have attention problems, or this child is oppositional, has a lot of anxiety, 20-year-old male at college, depressed. I want to just run through the first two because you're going to be able to see the difference between somebody who what we can measure about ADHD and what the difference is between the people who have it and don't have it in the testing that we are able to do. So I'm going to share the screen. So we're not going to go through this whole thing. You've seen some of these reports, right? They can be very long. This is an example of my report. Hopefully I have all the names off. So this was a 17-year-old female who was an 11th grader, and they presented with problems with academic problems, attentional problems, emotional concerns. She has a long history of anxiety, struggles with attention. Her parents believe she has ADHD because her brother does. And so we, not necessarily in this order, gave a nonverbal IQ test, because as we were going along in testing, it was clear that she was going to meet criteria for being dyslexic, having a reading disorder. Dyslexia is a language processing disorder, but our major IQ test that we give all the time, the Wechsler Intelligence Scale, is very language-based. And it also includes measures of working memory and processing speed right here. But if you give a nonverbal IQ test, this is not contaminated through reasoning with words whatsoever. This is really a peer measure of nonverbal reasoning. It's not timed, so there's no processing speed, and there's no working memory. It's really the ability to think and reason, but non-verbally, but it's still a reasoning skill. And there you can see her overall score is solidly average. When we come down here at the normal IQ testing, we see a markedly different score, because now we're looking at a lot of language-based scores. We're looking at processing speed, working memory, and that loads into this overall score of 79 and 8th percentile. And that should also be how she's performing in school, but it's not. She's performing closer to average. And so why are these two so different? Well, again, one has processing speed and working memory and a lot of language, this one. And this major IQ test is known, ADHD is known to depress IQ scores on this test. So this is an adult test, but hopefully somebody who's more experienced will give another, if time, IQ test to see other ways that they reason when it doesn't involve all those things. So again, we think this child is here. They think she's here because she has ADHD and anxiety. Everything's fine academically, or is it? So when we look at her reading, writing, and math, and we're using the ability achievement discrepancy model, anything that has an asterisk by it is statistically significantly lower than average and lower than her nonverbal IQ. So if I make this easy for parents, we have lots of asterisks here. We have one score that we have to understand, standard score with a percentile rank. So she is across the board full of asterisks. She struggles with reading everyday words, just sight words all of the time. And she's obviously worse at it when timed. Pseudo words are not nonsense words like MIB. So we all have to go into our upper left hemisphere and find what sounds go with these symbols that we're looking at and say MIB. And you can see that she's even a lower score when timed, which illuminates the amount of time it takes for her to go to this part of her brain and find what sounds go with the letters. That is the core deficit of dyslexia. And so we want to hear her actually read. She read a series of paragraphs out loud to me. Look at that rate. Is she going to be able to keep up in school with just a specific allotted time? No. Her accuracy was very poor. I'm listening to her reading so I can decipher errors that are more about decoding and dyslexia versus attention, and she had a little of both. Those combined for what we call fluency, rate, and accuracy. So she spent all of her energy trying to decode words. How much is she going to understand after that? So these two, interestingly, the Y it's for and the gray silent, she read silently to herself she could look back on these passages to answer the questions, yet her scores are markedly low, even when she was untimed and could look back. But when she read out loud to me, and she couldn't look back, so this is in some ways a working memory task, she did better. So why? So first of all, when you're reading silently to yourself, you're not necessarily paying attention, although that's not a conscious thing. And for her, she's getting to words that she does not know, and she's kind of guesstimating. You see him guesstimate. They use the first few letters of the word and they fill it in. They easily decode the beginning of the word, but when they go up to the upper left hemisphere to find the rest of the sounds that go with those letters, it gets jumbled, or as I like to say, there's quicksand and the lights are off. So when nobody's listening, they're skipping these words. They also might not be able to keep it in their memory as well. When she's reading out loud to me, she's not skipping the words because I'm sitting there looking at her, right? So she's trying to sound these words out. And of course, reading out loud is easier to remember something than reading silently. I know sometimes still when I get to something new I'm reading and it's more technical and I'm like, oh, wait, what was that? It can be amazingly helpful to read out loud. And it helps with her attention and her focus, but also her ability to decode new words. Now, that's not very practical when you're a 12th grader. And lastly, they give us this dyslexia index that's really looking at her ability to read real words, nonsense words. Again, this is the big kind of clue that we have more going on here. And then the speed at which she could read both real words and sight words. So this is a new finding in the parents' mind that, wow, what do you know, it is more than ADHD. I guess there's other issues here. And that's kind of also supported when you measure phonological processing, which is underlying foundational is needed to be able to be a good reader, just the ability to play with sounds and move sounds around. For instance, rhyming is innate. By about 4 or 5 years old, we hear a few words about rhyming, and then we can just take off and rhyme. We can move sounds and words, foundational and innate, except for the 20% of the population that's dyslexic. So I have some friends in the Atlanta area that are pediatricians, and they asked me how they can pick this up early. And I said, I want you to sit at the 4 and 5-year-old exam and play some rhyming games with them. They should know how to do it by that point in time. They all memorize cat and hat, but what about shoe? What about cup? What about phone? What about 2-syllable words? So we can pick this up at 4 and 5 years old. We can pick up that a child has a brain difference if you happen to have the ability to go to the MIT fMRI lab at 2.5 years old. But we do not have to wait for a child to struggle before we diagnose this and treat this. She didn't have any math learning disability, different part of the brain. We definitely expect her spelling to be lower than her same age peers. Spelling is mostly a phonics task, particularly in English, where we have close to 200,000 words. So when we're trying to spell a word, we have to come up with the right symbol, and we also have to come up with the right sound. So
Thank you.
Yeah.
Dr. Danielak,
I see that.
I should say, you are crossing your time. I would be so grateful if you could end the present sooner. Thank you.
So I'm sorry, I was trying to pay attention to the time. 20 minutes is so fast. So just briefly, this is a measure of executive functioning that we can see is normal for her. When we get, this is a measure of continuous boring attention, which is normal from her. So we don't find that she has ADHD. I should have just done all case presentations, but I didn't. So I'm sure they have this, the documentation if you want to look at it later. And I don't know if we're doing questions, and if so, I guess you have to put them in the screen, the chat screen. Yeah, there's so I need to stop because the next person is coming on. Thank you for your attention. sorry I didn't get through everything.
Thank you so much. I really wanted to